see the screen?
Yes.
Yeah. Okay. Good. Yes, you can record, Krupa. No problem. Okay. Good morning. I don't know what time is it for you. You're like you're 2 hours ahead of California, right?
We're 1 hour. It's
1
noon.
hour. So it's noon. Okay. So hi everybody. So welcome. Thank you very much for having me. I really appreciate being here today. Thank you, Krupa, for inviting me. Yes, Krupa and I we met about a year ago, a little bit less than a year ago, right? It was so for the Medical Student Fair Fellowship. It was an interesting time because it was supposed to be in person, and then we ended up doing everything virtual. That was in July when I became the chair, and there was a lot of things going on, and things seems to be getting a little better right now. With COVID, it's been a very intense year. And I know it's been intense for anesthesiologists, critical care physicians, but also medical students and trainees in general, because it's not been only intense at work, but it's also been intense at home, socially, and in whatever we do. So again, I've been at UCLA for about 5 years. I became the chair in July, on July 1st. 2020. Before being at UCLA, I was at UC Irvine. UC Irvine is about 50 miles south of Los Angeles. I was in Irvine from 2009 to 2016. When I was at UC Irvine, I was director for cardiac anesthesia and vice chair for research. I moved to UCLA, and I was vice chair for perioperative medicine and vice chair for research. And I became the chair a few months ago. And before joining UC Irvine in 2009, I was actually in France. I was trained in France. I did my residency in France, medical school. I worked as a faculty for a few years before I came to California. Today, Krupa asked me to present some of the research we do at UCLA, and especially the research that I am doing. My research has been focusing initially, my PhD is in cardiovascular physiology. And especially my early research was on the concept of the cardiopulmonary interactions, the relationship between the lungs and the heart. And especially that's relevant to anesthesiologists, because when we place patients under general anesthesia, we put them on a mechanical ventilator, and we are using a positive pressure ventilation, as opposed to the way we are breathing right now, which is a negative pressure ventilation. And when you use a positive pressure ventilation, you increase the pressure in the thorax during inspiration, and that has an impact on the venous return, that has an impact on the heart, it has an impact on the afterload of the heart. And so these cardiopulmonary interactions can be used to assess a lot of things, including the volume status of a patient through indices such as pulse pressure variations and others. So that was my early research back maybe 15 years ago. And then I moved from like the purely physiological research to the application of technology on physiological signals, and especially on physiological waveforms. So how do you take physiological waveforms like the arterial pressure waveforms, the central venous pressure waveform, the SpO2 waveform, or other waveforms, and then you apply new analytics, new technologies to the analysis of this waveform. And especially my interest has been on the application of artificial intelligence, computer science techniques, machine learning to physiological waveforms and other kind of healthcare data. To develop algorithm that we call predictive algorithm. So that's what I'm going to present you. Another part of the research that's associated to the artificial intelligence and the machine learning, that my lab is actually developing an autonomous system to deliver anesthesia automatically. So robotic anesthesia, autonomous anesthesia system, and I will go over this with you. But before we start, I would always like to remind people what it means to be an anesthesiologist. Why is it a profession that has had so much impact? The first thing for you to understand is that actually anesthesiology is a very young medical specialty. 70 years ago only did we start seeing actual department of anesthesiology being developed in the United States and in Europe. More than 70 years ago, there was no anesthesiology department. Anesthesiology was first demonstrated in 1846. It took about 70 years for anesthesiology to become an official profession with structured departments of anesthesiology. And before 1846, there was no anesthesiology. That did not exist. There was a lot of medical specialties. There was a lot of surgical specialties. But anesthesiologist by itself did not exist. And you have to understand that before anesthesiology ever existed, the only surgery that was basically doable was amputation, whether it's a limb amputation, whether it's a tooth extraction. You could not do surgery on anything else. You could not do surgery on the abdomen. You could not do surgery on the thorax. You could not repair any limb, any articulation. You could not do, obviously, surgery on the heart, surgery on the brain, surgery in the mouth. So anesthesiology, really the value that we brought is that we allowed surgery to expand. There would be no surgery without anesthesiology. Technically speaking, you could take a cadaver and repair the heart, change a valve on a cadaver. Technically speaking, you could do that with your hands, some stitches. But until anesthesiology made it possible to stop the heart, open the heart, repair it, and start the heart beating again, there was no ability to do surgery on the human being while maintaining this person alive. So that's really the key value that we brought. That was in 1846. That's a representation of the first anesthesiology performed in Boston at the Massachusetts General Hospital in 1846. And what you can see is that the first time anesthesia was demonstrated, you had one patient here for a demonstration, surrounded by about 9 physicians. 9 physicians for only one patient. This patient did not have any surgery. It was purely a demonstration of anesthesia. And you had a physician-to-patient ratio of 9:1, which is very, very different from what we see today in anesthesiology, where you have, for example, on this picture, 2 surgeons, a patient, an anesthesiologist who's behind a cell phone taking a picture. And what you see, the big difference with the other picture, the one that we just saw here, the big difference in what surrounds the patient today is technologies. You have monitoring technologies on this side of the screen. Here you have the general monitoring screen. Here you have the anesthesia machine. Here and here you have other monitors. This one is for cardiac output monitoring. This one is something that measures the EEG of the patient to assess the depth of anesthesia. And on the other side of the patient, you have another type of technologies, which are not monitors, which are called drug infusion devices. These are the pumps that delivers medication to the patient. And this setup is about the same in the operating room and in the ICU. You have monitors that are measuring, and you have drug infusion devices that are administering the medication. In between these two kind of technologies, you have usually a provider that could be an anesthesiologist, a nurse anesthesiologist, could be a nurse in the ICU that bridges the link, bridges the side of this patient with the monitoring technologies and the other side with drug infusion devices. And the provider in between can choose to use, for example, the lines here to administer medication and so forth. So that's the framework. If you look at the screen, there is something that has almost disappeared today compared to when this picture was taken. Is this piece of paper here that was the anesthesia chart. And this picture is not that old. That's a picture that was taken maybe 7 years ago. And at the time, there was no electronic medical record. All the vitals from the monitoring screen, as well as the medication delivered to the patients, were recorded on a sheet of paper that was called the anesthesia chart. All these cases then were abstracted, stored somewhere in the hospital in archives. And you could go back and find patients' data on the anesthesia chart that would take forever. Today, this has been replaced by the electronic health record. Today, most hospitals, at least academic hospitals, are equipped with electronic medical record system. what this has changed in the operating room is that about 10 years ago, the hub of medical technologies in the operating room was this monitor here. It's the general monitoring screen, where most of the information from the other devices would be displayed on this monitor. Today, this ecosystem has changed, and the electronic health record really became the hub, the technological hub in the operating room or in the ICU. But something that you have to realize is that over the past 5-10 years, since the electronic medical record has been created, we have generated billions and billions of data of patients undergoing surgery in the United States, but also in Europe and pretty much everywhere in the world. And this data, we just start using it. And what I'm going to do is to try to walk you through some of the potential application, looking at some of the history of the research we've done. We started doing this research more than 10 years ago, and where we are today and what could be the future. One thing also to understand in anesthesia is that one of the key contributions of the anesthesiologist to patient safety is that we have been able to make the place in the hospital where we deliver the most acute care, which is the operating room, we have been able to make it also the safest place in the hospital. It's pretty impressive. Today, when you go to the operating room, there is almost no death. It's very rare to have death in an operating room, very rare to have major complication. If you look at the safety in the anesthesia-related fields, it's very close to, it's basically at par with the airline industry, extremely close to the airline industry. One of the safest industry in the world, anesthesia. We've made the operating room the safest place in the hospital. That being said, when you look at the causes of mortality in the United States, and if you take post-operative mortality, which is any mortality occurring within 30 days after surgery, you can see that post-operative death remains the third leading cause of death in the United States. So the operating room is very safe, but the perioperative environment is not super safe. People still die after surgery. They don't die anymore during surgery, but they die within 30 to 90 days after surgery. So that's something to keep in mind, because if you choose to go to anesthesia as a specialty, you will quickly understand that the challenge of this specialty is going to be able to improve postoperative death. We've been very good at improving intraoperative death. Now we need to move outside and improve the postoperative death. That's why if you look at many anesthesiology departments in the country, they have changed their name from anesthesiology department to Department of Anesthesiology and Perioperative Medicine, because we identify that perioperative death is the next key challenge. So now let's go into the discussion of data technologies in the perioperative setting. So we are going to discuss the role of data in anesthesiology and perioperative care. We are going to discuss automation, and then we are going to discuss precision medicine. So data, that's the cover of anesthesiology. That's probably the number one journal in our specialty that was published in October 2018. And the cover of the journal back in the days, October 2018, was featuring 2 papers from our team, where we were the first team to use artificial intelligence in one paper to predict operative mortality, and in another paper to predict hypotension during surgery. And I want for you to keep this in mind, because we are going to look at this paper. One predicts postoperative mortality, so we are able to predict an event that occurs within 30 days after surgery. And the other paper is we predict hypotension during surgery. So we show that we are able to predict about 15 minutes ahead of time when a patient is going to start developing hypotension. And it's important to put these 2 papers head to head, because the time frame of prediction has a major impact on the kind of techniques you use to develop your algorithm, your predictive algorithm. To predict something that's going to happen in 6 months from now is completely different than to predict something that's going to happen in 15 minutes from now. You don't use the same techniques, and the challenges are different. But before we go into the details of data and how we use it in perioperative medicine, let's go back to what do we call big data. Big data has been a buzzword in healthcare and outside of healthcare for the past 15 years. And everybody's talking about it, but nobody really knows what it means and nobody really knows how to do it. I think the best definition of big data was brought up by IBM a long time ago. And they said that big data is defined by the 4 V's. The first V is for volume, is the scale of the data set, the size. So you could have a very, very large data set. For example, you could have a data set that's going to, I don't know, store the information and give you access to the information to every human being on Earth. That's going to be very, very big. But if this data set, for example, only give you enough information about the gender of the person, you could argue that it's a pretty limited data set. It's a big data set, but it's not a very rich and granular data set. The second V is for the variety of the data set. So if you have a big set of data, but on top of it, for each category, you have a lot of variables that is collected, then you increase the variety of the data set. So instead of just having the gender for your population, if you have gender and hundreds of other demographics, the variety of the data set starts being more and more important, right? So you have a big data set with a lot of information, a rich data set. But I could argue that if this data set is updated only once every 10 years, it's interesting, but it's not very dynamic. And so the third V of big data is the velocity of the data. The velocity of the data is how often the data is updated. And that relates to the information flow, and that also relates to the update pace of the data set. So again, if you have the same data set, but this data set is updated every day or every 12 hours, and you have something worldwide, then you start understanding a lot of things about, for example, the impact of gender, or the impact of weight, or the impact of your zip code on mortality, for example. You have a dynamic data set that changes constantly. And finally, the last V of big data is the concept of veracity, how accurate the data set is. For example, if you take something as simple as the BMI of a patient, the question is, how do you measure BMI? Is it self-reported? Do you actually base it on a weight that's measured using a digital scale, a mechanical scale? What height are you using to define the BMI and so forth? That's going to relate to the veracity of data. And so it's actually one of the key challenges today is to focus on the veracity of data when it comes to big data. So that's how you define big data. In healthcare, and especially in anesthesiology and perioperative medicine, what you have today, you have electronic medical records that accumulate and store in health information of every patient in the hospital, including surgical patient. You have what we call anesthesia information management system. These are anesthesia charts that are electronics. Usually they are part of the electronic medical record. And then what we have is that we have a ton of databases where we have, for example, the outcome or the incidence of complication or disease after surgery for every patient undergoing surgery in the United States. So you have data about the process of care in the electronic medical record and the anesthesia information management system, and you have data about the outcome of this patient. So when you pair everything together, you start understanding that if you have a volume that's big enough, data sets that are pretty rich with high velocity and that are accurate, then you can start developing algorithms to better characterize or better understand the health of your population. There is another evolution of big data, which is called what we like to call smart data. And the smart data is not based on the data set itself. It's based on the kind of analytics you apply to your data set to extract value from the data set, right? And that's the fifth V of how to characterize big data. It's a V for value. How do you extract value from a large set of data? And the value is extracted by the analytics that you're going to apply to this data set. The first step of analytics is the most basic. It's descriptive analytics. You just give a photography at a given time of a data set. That's descriptive. The second step of analytics is the predictive analytics. using this data set, you are going to be able for specific patients to predict what's going to be the outcome of this patient or what treatment is going to lead to the best outcome for a given patient with a given disease. That's called the predictive analytics. The prescriptive analytics is the next layer, the next step of analysis is related to once you can predict that something is going to happen for a patient, the prescriptive analytics is going to tell you what can you do to either achieve the best outcome for the patient or avoid the worst outcome for the patient. Prescriptive analytics is when the computer tells the clinician what to do to achieve the outcome he or she wants to achieve. That's the concept of prescriptive analytics. The last scale, the last level of analytics is the cognitive analytics. It's when computer starts to predict, prescribe, and make decisions on themselves and learn from their own mistakes. When you get into cognitive analytics, you get very close to the concept of singularity. That's a little bit of science fiction concept when computers start thinking by themselves and make decisions and everything. And that leads to the concept of automation. And we'll discuss this today. Again, when you look at the perioperative setting, the way these systems are meant to be deployed is, for example, here you have a representation of an operating room, right? An intensive care unit with floors. Patients could go to the surgical ICU, to the pre-op area, to the ICU, to the OR, to the recovery, the PACU. Information there are collected via a lot of different sources, anesthesia machine, ventilators, monitors, nursing annotation. Everything goes to a computer into the electronic medical record. This information is constantly, on a continuous basis, analyzed. Patterns in the data set are linked with outcome, for example, a code blue or cardiac arrest. And this is fed into a neural network. And what the system does moving forward is when the pattern of data that was in the past associated with a cardiac arrest, when the computer detects this pattern in a specific patient, the computer is going to alert the team and tell the team this patient is at risk of developing cardiac arrest, for example. That's the kind of clinical decision support system, or what we call early warning system, that can be implemented, that already exists. You have systems like this existing in some places in the electronic medical record. Some places like to call the system sniffers, in that they are able to detect very early on when a patient is going to have a risk of developing, for example, sepsis, cardiac arrest, code blue, or whatever. That's one of the papers we published in Anesthesiology in 2018. In this paper, what we did is that we developed a deep neural network to predict postoperative in-hospital mortality. So what we did in this paper is that we had a group of 150,000 patients where we had all the information pre-op and intraoperatively, including the drugs that the patient were receiving during surgery, how long was the surgery, the blood loss, a lot of information, more than 200 features, 200 variables. And we developed a deep learning model to predict postoperative mortality at the end of surgery. And what we did is that we compared this deep neural network model to other risk factors for mortality, like the APGAR score, that's the black line here, the POSPOM or the ASS score. And you can see that our deep neural networks, these are the ROC curves here that we have, they perform much better than other risk factors for prediction of mortality. And the interest of a deep neural network is that you can deconstruct a deep neural network. So deep neural networks can tell you, for example, this patient is at risk of mortality, and the system can tell you, in my prediction of mortality for this patient, these are the reasons why this patient is at high risk. So for example, the system is going to tell you this patient is at high risk because the ASS score is high. Okay, that's interesting, but there's nothing you can do about it. But the system can tell you, for example, I predict this patient has a high mortality because the starting hemoglobin of this patient is low. As you can see here, for example, the starting hemoglobin has a pretty heavy weight in the prediction of mortality. What it means is that the system is able to tell you to some extent that you could correct some variables before surgery, and that would potentially reverse the risk of mortality for a specific patient. Because these systems are able to be interpreted and to give you more information. So not only is it able to very accurately predict for specific patients what is the risk of developing complications. So we do the same kind of work after that for postoperative acute kidney injury, sepsis, reintubation, and so forth. It can predict very accurately, but it also can help you understand why a specific patient is at risk of this complication, and you can potentially reverse some of these features. So this kind of work is based purely on electronic medical record data. It means it's a pretty low granularity data. It's not a data set that's extremely rich. It's going to give you, if the patient is diabetic, yes, no, what is the hemoglobin level, what is the blood pressure level, what medication the patient is taking. So there's a lot of features, but each feature has a limited data set. It's not very rich. So now you can use artificial intelligence and machine learning and apply it to more complex data. For example, that's a paper we published in 2007, where the idea here was to develop a system to use artificial intelligence and measure the ejection fraction of patients based on the ultrasound of their hearts, and to measure ejection fraction automatically using artificial intelligence. So that was published, you see, more than like 14 years ago, right? This kind of system has been here for a long time. So how do you develop a system like this? The first thing is that you need to create a database with a lot of ultrasound pictures of the heart, ultrasound movies, 4-chamber views and 2-chamber views, right? So for this study, we had more than 10,000 4-chamber views and 2-chamber views of the heart. You need to then develop a system that's based on pattern recognition for the computer to recognize the left ventricular cavity. Once it recognizes the left ventricular cavity, it needs to trace the border of this cavity. You need to teach the system how to do that. Then the system needs to track the border of the cavity on each frame on a movie. And then it needs to measure the left ventricular volumes, the end diastolic volume and end systolic volume, and then measure the ejection fraction. So for example, I give you an example. You can see here you have a 4-chamber view. The system is going to detect the left ventricle here. You can see that it excludes the papillary muscle. So it learns that papillary muscle needs to be excluded. It's going to track. And then the system is going to output the end diastolic volume, the end systolic volume, and the ejection fraction. And so when we did that, we developed the system on about 10,000 views of the heart, and we tested the system in views that the system had never seen before. And we were able to show, for example, here that if you compare the computer, the ability of the computer to measure ejection fraction on ultrasound, and you compare it to cardiologists, expert cardiologists, you have a very good relationship and a very good agreement. We also showed that the system is able to measure ejection fraction with an accuracy that's as good as cardiac MRI, which is the gold standard for ejection fraction. The cardiologist is not a gold standard. The gold standard for ejection fraction of the heart is cardiac MRI. And then what we did is that, and that's where I think the paper got accepted in this journal, which is a very, very good journal, the Journal of the American College of Cardiology. What we did is that in this study, we asked residents who were only 1 month in residency. And we asked them to measure the ejection fraction of patients. And we compare the ejection fraction of patients measured by residents to cardiologists with 30 years of experience in cardiology. And when you compare a resident to an expert, you can see the relationship is not great. And the agreement is not very good, right? But what we did then, we gave the artificial intelligence system to residents, and we asked residents to evaluate the ejection fraction of patients together with the artificial intelligence system that we had developed. And we compared the duo, residents and AI, compared to expert cardiologists. And what you can see that when you give the system to a resident, within a day, they perform as well as an expert cardiologist. And that, I believe, that captures the potential benefits of AI system. These systems are not meant to outperform experts, but they are meant to take mid-level providers or trainees and to, within a few hours, make them operate at the level of an expert very, very quickly. You could argue that in terms of patient safety, that's probably a major win. This kind of research has been reproduced many times. So that's, for example, a paper that was published in 2018. Google actually published this paper in the JAMA. And what they did in this study, they took the pictures of the retinal fundus, and they developed a system to diagnose automatically diabetic retinopathy. And they showed that the computer, if you train a computer very quickly, the computer can learn how to diagnose a diabetic retinopathy, as well as an ophthalmologist with decades of experience in ophthalmology. And obviously, imagine that the cost of the system is way lower than the cost of a human being. It's also way faster. It achieves an economy of scale that you cannot with a practitioner, but it also disrupts the profession of this ophthalmologist. Another potential application of AI, which is very specific to what we do in anesthesiology and critical care, if you think about it, a big source of data for us are the waveforms that we have on the monitor, the physiological waveforms. And so that's the kind of research we've been developing since July 2013. So we started about close to 8 years ago, where in every operating room at UC Irvine and then at UCLA, we have a system that continuously records every physiological waveform that we have from every monitor in the operating room, in the ICU, on the floor, in the recovery room. All these waveforms have been constantly collected since July 2013. So as of today, so that's a framework where all the information is collected. As of today, and this slide is almost 3 years ago. So at the time, we had already 2.5 million minutes of continuous recording of waveforms, the equivalent of close to 2,000 days of continuous recording of physiological waveform. Today, we probably have more than triple what we have on these slides. We are close to 6,000 or 7,000 days of continuous recording of high fidelity physiological waveforms and others. So it's a lot of data. You can imagine how many heartbeats we have collected, how many EKG waveform, arterial pressure waveform, SpO2 waveform, any kind of waveform, high fidelity we've recorded over time. And so one of the first projects that we developed is that we thought, hypotension during surgery has been shown to lead to mortality after surgery. And today, the way we treat hypotension in the ICU or during surgery, that when we see the blood pressure drop, we react and we treat it. And so what we wanted to do at the time is, what if we were to develop a system that would tell the clinician 15 minutes before hypotension happens, and would trigger an alert so that the clinician would know that the hypotension is going to happen, and the system would tell the clinician why hypotension is going to happen and what can be done to prevent it. And so how do you develop a system like this? Again, if you have millions and millions and millions of minutes of recordings, what you do is that, for example, here you have only 60 minutes recordings of the mean arterial pressure. We see the mean arterial pressure in this patient is around 80, so it's a normal blood pressure. It's about 60 minutes recording. And what you can see that at this stage here, the patient is going to develop hypotension. The blood pressure is going to drop. So you define hypotension with a blood pressure around 60 millimeter of mercury, that's hypotension. You see the patients here develop hypotension. And what you do, you go back 15 minutes before, when the patient has no hypotension, and then what you do, you biopsy the arterial pressure waveform. You take a biopsy of the waveform, high fidelity waveform. Okay, and if you do that on thousands and thousands of events, you know that every time you biopsy this waveform here, 15 minutes later, it's going to be followed by hypotension. Then what you do is you identify places where there is no hypotension 15 minutes before and no hypotension 15 minutes after. In the same way, you biopsy this. You biopsy this arterial pressure waveform because you know that this waveform here has no hypotension either before or after. And you are going to have two groups, a group of arterial pressure waveforms that are followed 15 minutes later by hypotension, and another group of waveforms where there is no hypotension before or after. And the idea is to try to identify, using computer science technique, are there patterns in these waveforms that differentiate the two groups, right? Can you detect patterns in the physiology that are going to help you predict when the patient develops hypotension? So what you do, you take a single arterial pressure waveform. You know that it's divided into 5 phases on an arterial pressure waveform. You have the systole, the diastole. During systole, you have 2 phases. You have the systolic rise and the systolic decay, and then you have the total decay of the arterial pressure waveform. And on each of these phases, you apply computer science techniques that are called feature extraction techniques, and you extract specific features from each portion of these waveforms. For example, you look at the slope of the systolic rise, the slope of the systolic decay, you look at the area under the curve of the systolic decay, and so forth. And what you have to do, you can extract for a single arterial pressure waveform, you can extract up to 3,000 individual features. And what you do is that you say, okay, of these 3,000 features, which are the ones, when they are together at the same time, you have a strong probability that the patient is going to develop hypotension in the next 15 minutes. When you do that, you identify 51 features that predicts with an area under the curve of 0.85 or more, then the patient is going to develop hypotension. Then you take these 51 features and you combine. If you take 51 features, you combine them, you obtain 2.6 million features. What it means is that from a single arterial pressure waveform, you are able to identify 2.6 million features that, when they appear to be together, some of them are very predictive that the patient is going to develop hypotension. And then you take a threshold a little higher, an area under the curve of 0.95, and identify that of these 2.6 million features, there are 22 of them that, if they happen to be exactly together at the same time in a given patient, you can be sure, almost sure, that in the next 15 minutes, if you don't do anything, the patient is going to develop hypotension. And that's how you develop predictive analytics using a physiological waveform. And in this study, we are able to show that, yes, the system is extremely predictive, 5, 10, obviously 15 minutes before the event. So that gives you an idea of what we can do with data. Just to finish now, let's go to automation. All these systems, the system I presented you, or what we discussed initially, are monitor systems. They give you an information on the screen, and you can do something about it. What we've been developing over the past 10 years are systems that takes the information from the monitors. This information goes to computers and software that we develop. This software analyzes the data from the monitor, and then they control the administration of the drugs using the drug infusion devices. It's called a closed-loop system. It's an autonomous system. So the system delivers anesthesia, vasopressor, fluid management automatically under the supervision of a human being. So it's not a new concept. Back in 1950, Charles Mayo developed a system to deliver ether automatically based on the EEG of the patient. That was really the beginning of automation. But here, for example, it's a case that we did in Europe, in Belgium, sometime maybe 4 years ago, and that we published in Anesthesia Analgesia. In this case, we had a patient who was scheduled for a major abdominal surgery. And what you can see in this patient is that here you have a hemodynamic monitor that measures the blood pressure, the cardiac output. The information from this monitor here are sent to this computer, and this computer has a software that's an automated system for hemodynamic management that's going to control the administration of fluid through this pump and the administration of vasopressor through another pump, phenylephrine and so forth. At the same time, in this patient, you can see here you have a BIS monitor that measures the depth of anesthesia. You have a monitor here that measures the nociception, that's called analgesia nociception index. These two monitors send information to this computer here. And this computer controls the administration of the drug that you see here on these pumps, propofol and the remifentanil. On top of it, here you have an anesthesia machine, the DUS from Draeger. That's this anesthesia machine that automates ventilation of patients. And what we did in this case is that we induced anesthesia manually, intubated the patient, We then connect the patients to the anesthesia machine and to the different computers. And for the rest of the surgery, all the anesthesia was delivered automatically and autonomously by this closed-loop system, by this software. All the drug administration were controlled not by the anesthesiologists and nurses in the room, but controlled by computer. It means the physician can come in, stop the monitor, stop the software, change the target. But what they do at the beginning, the clinician choose a target for blood pressure, a target for cardiac output, a target for the BIS, and then the system are going to deliver drug automatically to always be on target. I'm going to go quickly on this one. That's an example of a system we also developed for vasopressor administration, phenylephrine administration, where here you measure the blood pressure. The information is sent to this computer with a closed-loop system that controls phenylephrine drip. You can see here, for example, that's one of the first experiments we did on animals. We take some pigs under anesthesia, and then what we do is that we administer nitroprusside to induce hypotension. And in these 8 pigs here, we administer different doses of nitroprusside. The blood pressure goes down, but we don't do anything. In the other group, we do exactly the same thing. We anesthetize the pigs. We start nitroprusside in these pigs to induce hypotension. On top of it, we have a computer that controls the administration of norepinephrine to maintain the blood pressure. And this is what you get with the computer. You see the computer is going to control the blood pressure and maintain the blood pressure exactly the same level, whatever the changes you do in nitroprusside. So it's the equivalent of an air conditioning where you set the temperature of the room, and then based on the outside temperature, the system is going to blow warm or cold air. But here we do it with physiology and with drugs. I'm going to go quickly on this and just go to the last slide of this presentation. And that's the last thing I want to show you. That's an editorial that we wrote a few years ago. Whenever I've been presenting this topic, and I've been presenting it for more than close to 15 years, I've been working on these themes. 15 years ago, people were looking at me with like I was really crazy because that was the beginning. And today it seems like artificial intelligence, machine learning, autonomous system, it seems like it's completely part of our lives. But 15 years ago, that was really, really extremely disruptive, and people were always thinking so that our lab was only trying to replace anesthesiologists by developing computers. And so we wrote this editorial a few years ago trying to address this by saying, should we fear computers or should we fear the lack of computers? The first reaction when people look at computers automating the task that they are doing is that their job security is at stake. But what you could argue is that one of the biggest risks is that this system could be safer than what we do alone, and that working together with technology, we could deliver a safer level of care. And then the risk becomes if we place any barrier to the entry of these technologies in our profession, we're actually putting patient safety at risk. So one risk is for us to be replaced by computers. I really don't believe that's going to happen any time. I don't think that the jobs we are doing are purely technical. We have a job that's also ethical, compassionate, where we have to address and approach patients holistically. It's not only the drugs we push, the Severen canister that we turn, or the fluids bag that we open. It's much more than this. And I would argue that if you believe that anesthesia is just to push the drugs, open the bags of fluids, and turn the canister or intubate a patient, yes, if we think that's our job, then we'll be replaced. I believe our job is much more than just the technical part of it. So I'm one of those who believe that technologies are going to help us taking better care of patients. So that's the question, should we fear computer in the future, or should we fear the lack of computer in the future? Thank you very much. That was okay.
Thanks, Dr. Cannesson. Yeah, that was really interesting. And we also really appreciate you being here. Do you have time for a few questions if anyone has them, like in the next 5 minutes?
I have a question. Can you guys hear me?
Yes.
Okay. So I have a question about the utilization of big data in predicting, I guess, mortality. Is there any, or have you guys done any research on, I guess, comorbidities that cause mortality during anesthesia or during operation, like pre or before operation or after operation? I realize that most of your research is during is prediction of mortality during operation. I think you might be muted.
Yeah, sorry. That I was saying that's a very, very good question. We started with predicting mortality at the end of surgery. Then we moved and we worked on predicting mortality before surgery, right? And then adjusting the preoperative mortality prediction, adjusting it with the intraoperative mortality prediction. If you think about it, you can have a patient who has a high prediction of mortality before surgery, but then the mortality prediction at the end of the surgery, when the surgery is done, could actually become lower than it was before the surgery, or it could actually become higher. So you have to adjust the risk. Risk is not something static. Risk is something that evolves over time. I always give the example, if I start driving and I haven't drink any alcohol, my risk is X. And every time I'm going to drink a beer driving, my risk is going to augment, right, with time, primarily. So the risk is never static. It changes over time. And the next step has been to develop what we call interpretable machine learning algorithm, because machine learning are often considered to be kind of magic boxes where we don't exactly know how the algorithms are working inside these boxes. Now the trend is to develop interpretable machine learning. If you think about it, you could take two individuals with the same risk profile, but their risk prediction is actually going to be different. Because there are a lot of interactions between, for example, the surgeon you're going to have, the hospital where you're going to have the surgery, the day of the week when you're going to have the surgery. Is it going to be at night or the weekend? So the two individuals could have the exact same risk profile, but their risk is going to be different because you have so many factors that get into a risk prediction that the risk profile from the individual actually just gives a small part of the equation. So interpretable machine learning today identify not only the risk profile of individual, but what makes them more at risk than other people. So we can understand where the prediction is coming from. Finally, there are a lot of ethical questions with risk prediction. The question is, for example, if someone has a very high risk of developing a complication, do you still do the surgery? And what criteria do you decide or not to do the surgery? If you push the extreme of the ethical concerns, you could say that someone has a high prediction of developing chronic disease. What are the insurance companies are going to do? Are they going to increase the insurance policy for a specific person because the risk profile is high? You also have risk of creating a lot of health disparity with AI because you need to use data sets that are diverse and that represents the diversity of the population, and especially underserved population, to develop predictive models. Because if you only use affluent data sets or data set from affluent neighborhood or data set that are not diverse, you're excluding from this prediction a major part of the population. So there are today a lot of ethical considerations when it comes to artificial intelligence and medicine that I could spend an hour discussing it. So it's a major topic right now.
When building your database, how do you go about diversifying your population? Is it just with the university's hospital, like the medical center's hospital, or are you operating or working at like a private hospital?
In order to diversify your databases for research, you have to do it proactively. If you rely only on the population that you're taking care of in your health system, you're only skewed and biased for the health system you have, and you depend only on the patient population that you have in your health system. For example, you come to Southern California at UCLA, even though the Southern California population is a very diverse population, UCLA does not have the most diverse patient population. We have a patient population that's extremely selected. We have a very high payer mix. We are not serving a lot of our communities that are in non-affluent neighborhoods. So for us doing research, or for us leading departments, what we want to do is to engage with other communities that are going to diversify the patient population that we are taking care of, just because it's the right thing to do in terms of care that we provide, but also it's the right thing to do in terms of the research that we do, because if we don't do that, we are going to exclude a part of the population from the research we do and from the progress we're going to make in medicine. So the only way you can diversify your research or your care is to actively engage. You cannot be just complacent and just wait for your population to become more diverse. You have to go and seek and partner with populations that are going to help increase the diversity of the population you're taking care of. If that makes sense.
Definitely. Thank you so much.
You're welcome.
I'm really interested in your research, and thank you for doing your presentation.
Of course, that's my pleasure. It's one of the most rewarding things to do when you're a chair, is to engage with students, with potential applicants, because every week we have 2 or 3 groups of applicants coming to us, right, for during the recruitment season. And I meet with all of them, not every applicant individually, to be honest, but with every group of applicants, I spend 30 to 45 minutes with all of them. And often applicants ask me, why do you, not every chair spend time with the applicants like this. And the reason I want to spend this time is because I strongly believe that. I know it sounds cliche, but I believe that the future of the department is going to be you. It's the applicants, it's the residents, and the faculty. So the biggest impact I can have on my department is by contributing to recruiting residents and then faculty, because you can have the best vision, the best program, the best logistics. At the end of the day, a medical department, it's made of people. And so you need to make sure that you select or you recruit the people you want to have to represent the group you have, with the diversity, the culture, the values that you want to promote. See, there are some questions here in the chat. You want me to take some of the question?
Sure, if you have time.
Yeah. What are some of the qualities, experiences that applicants have that stand out to you? It's a good question. Where's the question? Veronica Rosen. Okay, Veronica. So what I am looking for personally in applicants, I'm going to be very honest with you, very frank, and I'm not the one making the final decision on who's going to match with us, right? I have some input. I help recruit those that we really want to recruit. I'm going to call them. I'm going to do my due diligence. But in the end, it's a group that's going to be part of the recruitment, right? To me, I value, and it relates to my values, right? One thing is that, so I was born and raised in France. I'm a first generation high school graduate. Nobody in my family finished high school. I went to medicine because to me, it was almost science fiction for me to match in medical school and to become a physician. And I've always felt that to be a physician is a privilege. And I never chose medicine because of my rank in society, because of how much money I'm going to make. I chose to be a physician really because I felt that's a privilege. And I like to recruit. I like people who feel that to be a doctor is probably just honor they find in their life. It's a tremendous privilege. I like also people who approach medicine globally, holistically, who understand that health is a right and not a privilege. And these are the values I have. So I tend to select people on this basis. I look at scores, but I'm not a big score-oriented person. I'm a foreign medical graduate, so I had to come back to the United States. I took my step 1, step 2, and step 3 only maybe 5 or 6 years ago. I had to retake them. I score very poorly, but I passed. So I look at scores a little bit. It's not really to me, it's not a big, I know for sure that people are not defined by a score. So I look at it, but I know for sure you cannot define someone based on a score. And I want people who, when you run a program in a department, I always tell the applicants, the residents, when you are going to choose your program, wherever you go for residency, there is something I can 100% guarantee you. If you don't completely mess up your training, there is something I can almost 100% guarantee you is that after your residency, you will find a job. The residency is going to prepare you for a job. There's no question about it. You can go anywhere. But if you go to the top program, like UCLA or Hopkins, MGH, Stanford, at least at UCLA, what I know is that what we want is not only to prepare you for a job, we want to prepare you for a career, for a long-term career. Whatever you want to do, whether you want to be a clinician, a researcher, an administrator, a physician executive, if you want to do global health, be engaged in community, if you want to go to the industry. I'm looking for people who are seeking opportunities, who want to do an anesthesiology training, but who have a much broader and bolder view of their long-term goals. That's what I'm looking for. Okay?
Awesome. Thank you.
Thank you, Veronica.
I had a quick question if you have a moment. First of all, thank you for the wonderful presentation. And with the growth of AI and perioperative care, do you see anesthesiologist roles growing more and more in the preoperative area, as well as possibly even before patients are coming to the hospital for surgeries to minimize those risk factors?
Absolutely. There's a big push toward perioperative medicine, meaning pre-op like for preparation. We start doing now pre-op like telemedicine, try to get a sense of people's functional status before surgery, sometimes try to optimize or to change their trajectory before surgery, being engaged after surgery, so in the hospital, ICU, the floor, but also after discharge from the hospital. That's a big trend in surgical care, because we know that the outcome is not great. And we know that the outcome is not great because of the lack of preparation before surgery or because of complication after surgery. So, and the way I like to pitch it, for example, when I talk about perioperative medicine to the hospital leadership or to other academic institutions when I give lecture and stuff like this, is that, so again, you come to a place like a UCLA. UCLA is ranked number 4 hospital in the country, right? And consistently every year, it's like in the top 5, 6 hospital in the country. The top 5 or 6, it's always Hopkins, Cleveland Clinic, Mayo Clinic, MGH, UCLA. That's pretty much it. But you know, and everybody knows, when a patient comes to us, they don't always receive the best care. Some of them are developing complications. Some of them do not receive the best care. And if there is one thing I know, is that when they come to us, if there is one thing that is not lacking at a place like UCLA, it's excellence. We have the best physicians, the best surgeons, the best nurses. We have the best trainees, the most competitive residents, access to the newest drugs, access to the state-of-the-art therapeutics and technologies. So when the excellence that we have does not reach a patient and the patient develops a complication, it's not because the excellence does not exist where we are. It's because this excellence was not coordinated in such a way that it consistently reached the patient, right? And so that's the idea of perioperative medicine, is that you position a team of physicians before surgery and after surgery to make sure that this care is constantly coordinated. Otherwise, there is always something that's going to be missed. And in medicine today, when you perform medicine at the highest level possible, it's like being it's like in sports. It's like professional sports, like in athletes. Those who win are those who are going to really pay a lot of attention to what we call marginal gains. The little things that are going to increase your performance by maybe 0.5 or 1%, that if you add them up together, are going to make a big difference. It's like, for example, big athletes is about their diet. It's about the kind of water they drink, how many hours they sleep, what kind of shoes they wear, what kind of, like the technical fibers of their. And when you look at it, if I put like a new shoes on myself and I go play tennis, I'm not going to play better tennis. But when you're an athlete, at this level, they add all these marginal gains and they do better. When you do medicine in some of these top hospitals in the country, it's the same thing. It's not sports, but it's medicine. And then you have to go toward these marginal gains. That's perioperative medicine.
Wonderful. Thank you.
You're welcome. Krupa, thank you so much. I'm very proud of you. You're doing the right thing. It's great to see that. It's a pleasure to be here. So thank you so much.
Thank you again, Dr. Cannesson.
Bye-bye.
And thanks everyone for joining us.
Bye-bye.
Hope you enjoy this meeting. Bye.